You've been in the ER for hours. The doctor finally says you're being admitted, and you think the hard part is over. But what happens next is a complex system most patients never understand, and knowing how it works changes everything about your hospital stay. Let's start with what being admitted actually means. The ER doctor has decided you're too sick to go home and need continued hospital care. But you don't just get wheeled to a room. First, they have to find you a bed. There's a bed management team whose entire job is playing Tetris with hospital beds. They're looking at which floors have open beds, what kind of bed you need based on your condition, and how sick you are compared to other patients waiting for beds. Here's what patients don't see. You might wait hours in the ER after being told you're admitted because there are no available beds upstairs. The hospital is full, patients aren't being discharged fast enough, and you're stuck in ER limbo. The ER staff is still monitoring you, but you're technically an admitted patient taking up an ER bed that's needed for new emergencies. This is why ERs get so backed up. Admitted patients boarding in the ER create a bottleneck. Once a bed opens up, you get transported to a floor. Here's where things change dramatically. In the ER, you had an ER doctor managing everything. Now you have a hospitalist, a doctor who specializes in inpatient care. Or your condition might require a specialist like a cardiologist or pulmonologist to be your primary attending physician. That doctor might not see you for hours after you arrive on the floor because they're managing 15 to 20 other patients simultaneously. If you're learning what really happens behind hospital doors, hit subscribe. We're revealing the system that controls your entire hospital stay. Let's talk about the admission process once you're in your room. A nurse comes in and does a full assessment. Vital signs, medical history, medication reconciliation, fall risk assessment, pain level. They're inputting everything into the computer system. Then you meet your nursing assistant who explains how to use the call button, where the bathroom is, and when meals are served. It feels like administrative paperwork, but they're establishing baselines and identifying risks. Here's what happens that you don't see. The hospitalist is reviewing your ER records, lab results, imaging, and admission diagnosis. They're formulating a treatment plan. They're ordering medications, consultations with specialists, additional tests, and establishing goals for your hospitalization. This all happens electronically while you're settling into your room, wondering why nobody's doing anything. Now let's talk about rounds, because this is when decisions about your care actually get made. Early morning, usually between 6 a.m. and 9 a.m., the medical team rounds on patients. For teaching hospitals, this might be an attending physician with residents, interns, and medical students. They go room to room, reviewing overnight events, checking patients, discussing plans. This is when they decide if you need more tests, if treatment is working, if you can go home. Here's what frustrates patients. The team might pop in at 7 a.m., wake you up, ask a few questions, examine you briefly, then leave. You have no idea what's happening. That's because the detailed discussions happen outside your room. They're reviewing your chart, looking at test results, debating treatment options, and making collaborative decisions. Then someone comes back to tell you the plan, but often that's hours later. Let's talk about why hospital care feels fragmented. You've got the hospitalist managing overall care. You've got specialists consulting on specific issues, cardiology for your heart, nephrology for your kidneys, infectious disease for your infection. Each specialist sees you separately, often at different times. They each have their own opinions and recommendations. The hospitalist is supposed to coordinate everything, but communication isn't always seamless. You end up hearing different things from different doctors and have no idea who's actually in charge. Here's what makes this worse. Shift changes. Your nurse works 12-hour shifts. Your hospitalist might be on for a week, then a different hospitalist takes over. Every time there's a handoff, information can be lost. The new nurse or doctor is reading notes, but they weren't there for the nuances of your case. This is why hospitals have strict handoff protocols, but things still slip through cracks. Now let's talk about why everything takes so long in the hospital. You need a CT scan. It gets ordered, but the CT schedule is full, you're not the most urgent case, and you wait. A specialist consultation is requested. That specialist has their own patient load and surgical schedule. They might not get to you until the next day. Lab results take time to process. Medication orders need pharmacy approval. Everything requires coordination between multiple departments. If this is opening your eyes to why hospital stays feel so slow, make sure you're subscribed. We're breaking down the reality of inpatient care. Let's talk about hospital schedules, because your care revolves around them whether you like it or not. Vital signs are checked every 4 hours. That's why nurses wake you up at 2 a.m. to take your blood pressure. Medications are given on strict schedules. Blood draws happen early morning because doctors need results for rounds. Meals are delivered at set times. Physical therapy comes when their schedule allows. Your sleep and comfort are secondary to the hospital's operational needs. Here's something patients hate: the constant interruptions. You're trying to sleep. A nurse comes in for vitals. Then someone draws blood. Then the doctor rounds. Then physical therapy arrives. Then dietary asks about meal preferences. Then environmental services cleans the room. Then a student wants to practice examining you. You never get uninterrupted rest, which is ironic because rest is supposed to help you heal. Now let's talk about hospital-acquired complications that nobody tells you about. The longer you're in the hospital, the higher your risk of getting sicker. Hospital-acquired infections happen because you're surrounded by sick people and antibiotic-resistant bacteria. Pressure ulcers develop from lying in bed too long. Muscle atrophy starts within days of immobility. Delirium is common, especially in elderly patients, from disrupted sleep, medications, and being in an unfamiliar environment. Here's what hospitals do to prevent this. They get you up and moving as soon as possible. Physical therapy isn't just about rehabilitation, it's about preventing decline. They rotate your position in bed. They use special mattresses to prevent pressure sores. They try to minimize unnecessary medications. But hospital stays are inherently risky, which is why doctors push for the shortest stay possible. Let's talk about discharge planning, because it starts the moment you're admitted. A case manager or social worker is already thinking about where you'll go when you leave. Can you go home? Do you need home health care? Do you need a rehab facility? Do you need medical equipment? They're coordinating insurance approval, arranging services, scheduling follow-up appointments, all while you're still being treated. Here's what creates discharge delays. You're medically ready to leave, but insurance hasn't approved the rehab facility, or the rehab facility doesn't have an open bed, or your family isn't prepared to care for you at home, or you need medical equipment that takes days to deliver. Patients get frustrated because they feel fine and want to leave, but the system is waiting on logistics. Now let's talk about why you can't just leave when you want. Technically, you can. It's called leaving against medical advice, or AMA. But doctors will strongly discourage it because you're not fully treated, you might deteriorate. And if something bad happens, it's on you. Insurance might not cover subsequent care if you leave AMA. It's your legal right, but it's a bad idea most of the time. Here's the financial reality nobody explains clearly. Being admitted triggers different insurance rules than ER visits. You've got copays, deductibles, and coinsurance. Every day in the hospital costs thousands of dollars. Every test, every medication, every consultation gets billed separately. You might leave with a $50,000 bill even with insurance, and you don't know the cost until weeks later when bills start arriving. Let's talk about what happens during your stay that determines how long you're there. Doctors are balancing two opposing pressures: discharge you too early and you come back sicker, keep you too long, and insurance refuses to pay. They're documenting that continued hospitalization is medically necessary. They need to show you're improving, but not yet stable enough for discharge. Here's how they decide. Can you eat and keep food down? Are you maintaining your own oxygen levels? Is your infection responding to oral antibiotics you can take at home? Can you walk safely? Do you have someone at home to help you? Are your vital signs stable? If the answer to all of these is yes, you're getting discharged even if you don't feel 100% recovered. Now here's what happens when things go wrong during your hospital stay. You develop a complication, maybe an infection, maybe a medication side effect, maybe you fell. This triggers incident reports, investigation, additional monitoring. Your discharge gets delayed. More specialists get involved. What was supposed to be a 3-day stay turns into 2 weeks. Here's the emotional reality of being hospitalized. You're in a strange place, poked and prodded constantly, sleep deprived, worried about your health and the cost, and you feel powerless. Hospital staff seem to operate on their own timeline, and you're just along for the ride. It's dehumanizing even when the care is excellent. What really happens after you're admitted is a complex dance of medical care, logistics, coordination between multiple departments and specialists, insurance requirements, and operational constraints. You're not just a patient healing, you're a case being managed through a system. Understanding that system helps you advocate for yourself, ask better questions, and manage expectations about what your hospital stay will actually be like.